Good evening, everyone. Good evening, Natarajan sir. Sorry for the delay for technical issues. As a part of Cardiovascular Research Society, this is a heart failure conference what we are going to plan on. And because of this hectic COVID times, we had to just postpone it and delay it for the month end. For today's sessions, we have got as a chairperson, Dr. Natarajan, who is the professor and former HOD at Amrita Institute of Medical Sciences. A warm welcome to you, sir, and sorry for the delay for waiting. And along with him, we have Dr. Praveen Srikumar, who is a cardiologist and electrophysiologist at Aster Medicity. He has just reached and he will be joining in a couple of minutes' time. And I hand over to the chairperson, Natarajan sir, to take over the session. Over to you, sir, to introduce the speaker. I think Dr. Jabir will be giving the first speech as Dr. Tachal is still in the procedure and he'll be joining soon.
Thank you, Dr. Jimmy. Can you hear me?
Yes, sir, we can hear you well, sir, and you are visible too.
So at the outset, I thank the Cardiovascular Research Society for having organized this meeting amidst the third wave of the COVID pandemic. And I see a lot of interest in these two talks. There are already 91 people who have logged online for this session. And we have two interesting talks. The first talk is by my good friend, Dr. Jabir. There's a echo actually. So the first talk will be by my good friend, Dr. Jabir, who will speak about the management of heart failure with reference to the recent developments, and that's why it's called Treatment of Heart Failure in 2022. Dr. Jabir?
Nataraj, I'm here.
And I have heard Jabir give the same talk as a snapshot in 2021, 2019, multiple places. It looks like heart failure management is a topic very close to his heart. So,
thank you, Nataraj. It's a pleasure to see you at least online. You should have been here.
So, Jabir, you can give your talk for the next. It's a 30-minute session, so you can.
All right.
Yeah,
so I think I'll be able to do it in 20 minutes or so, because after me, Dr. Ajit Tachal will be doing another 20 minutes. So as Dr. Nataraj told, I'll be talking about management of heart failure and reduced ejection fraction, a snapshot. So what's leading on to heart failure? It's a myocardial injury which decreases the ventricular performance, finally leading to a decrease in cardiac output. And in turn, what happens is activation of the neurohumoral system. The first one is sympathetic nervous system, followed by the RAS system, then the ADH system and other neurohumoral systems are activated, which first acts as a compensatory mechanism. And as the time goes on, it becomes more active and becomes counterproductive, leading on to vasoconstriction, water retention, sodium retention, and the further increase in demand of the heart, leading on to further myocardial injury. So this is the maladaptive cycle of heart failure and reduced ejection fraction, which is a vicious cycle. And this is a progressive disorder with a vicious cycle of progressive worsening. So from patients who are at risk of heart failure with a diabetes or hypertension, they develop a structural heart disease like left ventricular hypertrophy, chamber dilatation, or coronary artery disease, leading on to ventricular dysfunction, leading on to heart failure, first amenable to medical therapy, then refractory to medical therapy, finally end-stage heart failure, and in between multiple times they may get admitted. It's a progressive condition, and you can see just like the graph on one side, there is a worsening, improvement, further worsening, improvement, worsening. So the trajectory of heart failure is progressive worsening. In between multiple times they may worsen, balance, come back to near normalcy, then again worsens. And if you look at the data available regarding the hospital admissions, it's almost 60% may get a readmission in a year, and 50% dies in 5 years, and around 80% readmission in 5 years. So progressive signs and symptoms of heart failure for which medical treatment is warranted despite the use of all guideline medical directed medical therapy. So over the years, I'm not going to talk each and everything about the AC inhibitors, ARB, or standard guideline directed medical management. Till 2000, we had evidence-based medication in heart failure with ample evidence of data with beta blockers, RAS inhibitors. And then from 2000 onwards, drugs as well as devices. Dr. Nataraj is an expert in the device therapy for heart failure. So I think he will discuss that part also. Then we had trials like the COMET trial, where there was a beta blocker, the metoprolol was pitted against carvedilol. The CHAMP trials with angiotensin receptor blockers, the companion trial in 2004 with the device, the SED-HEFT trial with the device, the CARE-HF with devices in 2005. Then it becomes standard, the ICD becomes standard of care in heart failure and reduced ejection fraction. Nebivolol in 2005, then HEAL with the large dose of ARBs. Then the CRT trials came in with the MADID CRT. Then the STITCH trial, which looked at the revascularization. And almost from 2000 to 2014, we had multiple trials and devices. Then in 2014 came the landmark trial of paradigm heart failure trial after a period of almost 14 years since the introduction of beta blockers, mineralocorticoid receptor antagonists, and beta blocker and AC inhibitors. The paradigm heart failure, which found that there is an additional 20% mortality reduction over and above that of a background standard medical therapy, including enalapril. Then after 5 years in 2019, it is the DAPA-HF with the concept of use of SGLT2 inhibitors in heart failure and reduced ejection fraction. Then further supported by the data from the EMBERER reduced, and then in 2020, the GALACTIC-HF and Victoria, and in 2021, heart failure and preserved ejection fraction, we had the trial of the empagliflozin, the empagliflozin preserved trial. The EMPEROR preserved. So in heart failure and reduced ejection fraction, if you look at the game changers in the last decade, the paradigm heart failure in 2014, DAPA-HF in 2019, Victoria in 2020, in Vericiguat. The GALACTIC-HF used the cardiac myosin activator. Then the SGLT2, the empagliflozin trial, the EMBERER reduced, the soloist worsening of heart failure trial with sotagliflozin, which was a SGLT2 plus SGLT1 inhibitor. So that is a dual inhibitor of the SGLT. And later on, the EMBERER preserved. So this is the data available. Activation of the neurohormonal mechanisms, beta blockers, which reduces the risk of death, 34% relative risk reduction versus placebo. RAS inhibitors, 16% to 27% versus placebo. Mineralocorticoid receptor antagonist, 30% versus placebo. And ARNI, another 20% additional advantage when we compared it with the AC inhibitor plus MRA plus beta blocker. So heart failure with preserved ejection fraction, we are seeing some light at the end of the tunnel with the EMBERER preserved trial. And the disorders of metabolic inflammation, SGLT2 inhibitors, 25% relative risk reduction, the compound endpoint of death and heart failure hospitalization versus placebo. Then disturbance of cell metabolism, there comes the Vericiguat, then it is a 10% additional risk reduction versus placebo. So the future of heart failure, so in 2022, the agents that we use are broadly neurohormonal antagonists, that is the beta blockers, RAS inhibitors, mineralocorticoid receptor antagonists, SGLT2 inhibitors, soluble guanosine cyclase stimulators, and cardiac myosin activators. The paradigm heart failure trial, everybody knows this slide we have been showing for last 4 or 5 years. Now the 5-year data is out, paradigm heart failure 5-year data in 2020. 20% relative risk reduction over median, duration of 27 months in predominantly class 2 and class 3 heart failure, 70% class 2 and very hardly a few patients on class 4. Most important thing, it is ambulatory stable heart failure and reduced ejection fraction patients. Does that mean we can translate this or extrapolate this data to acute heart failure patients? Paradigm heart failure, there were no patients of acute heart failure or hospitalized patients, but it was an excellent data. So people, it came in and this was with a single trial. With the background of a single trial, this drug was incorporated into the guidelines. Then later on came the Pioneer HF trial, not predominantly an outcome trial. They basically looked at whether it is possible to start this drug in hospital when a patient was admitted with heart failure and reduced ejection fraction decompensated. So heart failure hospital admission, the primary endpoint looked at is the NT-proBNP level from the baseline over 12 weeks, open label trial versus enalapril. So in hospital initiation of sacubitril valsartan versus in hospital initiation of enalapril. And they looked at outcomes also, but this trial was not adequately powered to look at the outcome. But what they found is that there was an early differentiation, separation of the curve from the day 14 onwards, and there was a reduction in the events, that is the cumulative incidence, the cardiovascular death of rehospitalization of heart failure. So this is possible. It was found that a large number of patients, up to 50% of the patient, they could reach the target dose of this drug in 10 weeks of time. So Pioneer HF gave us data that it's possible to start ARNI in hospital. A significant number of patients can tolerate it. In significant number of patients, this can be uptitrated to target dosage. There is a reduction in the congestion, that is the elevated LV and diastolic pressure that was evidenced by the reduction, significant reduction in the NT-proBNP. There was a reduction in the event rate also. So if one of my patients was a 54 years old male, non-diabetic, heart failure with reduced ejection fraction, you can see LV dilated, significant LV systolic dysfunction, who was put on, apart from the other drugs like beta blockers, diuretics, he was put on ARNI, and after 6 months, this patient who had a coronary angiogram showed normal coronaries. So we thought it could be dilated cardiomyopathy, but to our disbelief, after 6 months, the LV function was totally good. It was almost, the systolic function was almost normal. So this patient was continued on beta blockers, bisoprolol 10 milligram, and ARNI, the maximum dose of ARNI 200 milligram twice a day. So this is another concept which is coming up, and the trial which showed something that in heart failure and reduced ejection fraction, the heart failure may improve, but this improvement is not a permanent recovery except in certain recoverable or reversible cases of heart failure. So this is something called a remission. And if you withdraw the drugs, the disease modifying drugs, again the patient can go back to a relapse. So this data is from the TREAD-HF trial. So it's possible, and we have data to support this, whether there is an improvement in ejection fraction or reverse remodeling with ARNI. So this is the patients whose LV ejection fraction in 6 months improved from 25% to 55% and continued on ARNI and beta blocker. We have the data from the PROVE-HF trial, prospective study of biomarkers, symptom improvement and ventricular remodeling during Entresto therapy for heart failure. Improvement in ejection fraction over a year, the LV ejection fraction improved from 28% to 37.8%. A significant decrease in the LV and systolic volume, significant reduction in LV and diastolic volume, reduction in the LA volume index. That means there is a total improvement in the ventricular dimensions, ventricular function. So this is a remodeling, change in remodeling. Up to 12 months, within a period of 12 months, there is significant reduction or reversal of remodeling with improvement in the LV ejection fraction and other parameters which looked at the LV function. The meta-analysis which was published last year, the angiotensin receptor blocker, neprilysin inhibitor on cardiac reverse remodeling. decrease in the LV and diastolic dimension, decrease in LV systolic dimension and diastolic volume and systolic volume, reduction in the LV mass index, LA volume index, and increase in ejection fraction by and large to the tune of 5%. So this is a reality, a improvement in the LV function with the use of the current medical therapy. Pioneer HF trial, we found initiation of sacubitril valsartan led to a greater reduction in NT-proBNP concentration than enalapril. Transition study, they looked at whether it is feasible to start ARNI in hospitalized patient. So discharge was feasible with ARNI after acute heart failure event, and half of the patients achieving target dose in 10 weeks. The real world data, clinical effectiveness of sacubitril valsartan among patients hospitalized for heart failure with reduced ejection fraction. If instead of an ACE inhibitor or instead of an ARB, if the patients were started on a ARNI or from a ACE inhibitor or ARB, if they were shifted to ARNI, there was an improvement in the all-cause mortality. At discharge, sacubitril valsartan versus at discharge ACE inhibitor or ARB, you can see a significant difference in the graph, especially in the hard endpoint of all-cause mortality. So better shift to ARNI or initiate ARNI at the time of discharge if in a case of patient who was admitted with heart failure and reduced ejection fraction. So if you look into the data, SOLT trial, the CBIS2, the emphasis, so everything, there is some significant amount of residual problem. Even in the paradigm heart failure, you can see despite the use of the best 4 drugs, ARNI, beta blocker, mineralocorticoid receptor antagonist, still there was around 12% incidence of the primary endpoint. 13.3% incidence of death or heart failure rehospitalization. So there is a significant or a long road for us to travel to reduce this to further lower levels. So 13.3% despite the best treatment. So another drug came in, the SGLT2 inhibitors. Emperor reduced all-cause mortality, heart failure hospitalization or urgent heart care visit for worsening heart failure. The benefit appeared quite early at day 12. Statistical significance attained in a month's time. DAPA-HF, death, heart failure hospitalization, urgent heart failure visit, and also outpatient intensification of heart failure therapy by day 27, statistically significant difference between placebo and dapagliflozin. So these drug has been found to be highly beneficial, and not only highly beneficial, quite beneficial quite early. And if you look at the entire data, all these drugs were found to have, all these disease modifying medications were found to exert its benefit in a month's time. So early benefit, and we should not deny the early benefit to the patients who have a high mortality and morbidity. What is the use, what is there any additional benefit of SGLT2 inhibitors if the patient is already on ARNI? These 2 drugs are complementary therapies with distinct additive mechanism of action. So despite a baseline therapy with ARNI, SGLT2 inhibitors provided a benefit in terms of the combined endpoint of death and heart failure hospitalization as well as heart failure hospitalization. And the third concept is targeting the oxidative stress and inflammation. During heart failure or in a patient with heart failure, there is increased oxidative stress, reduction in the development, in the generation of nitric oxide, low nitric oxide bioavailability, decreased guanylyl cyclase stimulation, leading on to decrease in the cyclic GMB. So decrease in the intracellular cyclic GMB leads to progressive myocardial dysfunction, progressive vascular dysfunction, fibrosis, increased inflammation, and this leads to deterioration in the LV function. The Victoria phase 3 study, symptomatic chronic heart failure, class 2 to 4 with ejection fraction less than 45%, more symptomatic or more severe heart failure who had, most of them had a recent heart failure hospitalization within the 6 months. And you all know that each heart failure hospitalization begets another heart failure hospitalization, and each heart failure hospitalization increases the mortality. Or IV diuretic use within just 3 months. NT-proBNP more than 1000 in sinus rhythm, more than 1600 in atrial fibrillation. The time to cardiovascular death or first heart failure hospitalization, there was a difference. At the end of 10.8 months, there was a absolute risk reduction of 4.2% per year with an annual number to treat is 24. The mechanochemical cycle of myosin, from the time of our MBBS onwards, we have been seeing digoxin and we have been talking about the positive inotropic agents, but All the intravenous positive inotropic agents have been found to increase the mortality in heart failure and reduce ejection fraction. So, can we increase the contractility so that the ejection fraction improves, the heart failure comes down without producing adverse events? Omecamtiv mecarbil increases the entry rate of myosin into tightly bound force-producing state with actin. So, more hands pulling on the rope. It increases the duration of systole, increases the stroke volume, without increase in myocyte calcium, no change in the dP by dt maximum, and no increase in myocardial oxygen demand. Fantastic drug. So it could produce a positive inotropic effect without the detrimental effect of inotropicity. The Galactic HF trial, there was a borderline statistically significant improvement in the time to first heart failure event or cardiovascular death. Those with an LV ejection fraction of less than 20%, who had a baseline ejection fraction low, the statistical significance was little more better. So, a incremental benefit of each disease modifying agent, and this study which showed that association with the optimal implementation of ARNI, beta blocker, aldosterone receptor blocker and SGLT2 inhibitors with a quadruple therapy, the number needed to prevent one death at 24 months with quadruple therapy is only 3.9, and each drug was beneficial. And with further the second drug, it was an incremental benefit. It is not like that people are all worried if you give the 4 drugs together, that means, does it mean that there is an incremental benefit? Does it mean that it increases the chance of adverse effects? But here you can see the number needed to treat for 24 months with all 4 medical therapies to prevent a death is closely 4. Provided the drugs are taken, each therapy is optimally dosed, each therapy is optimally monitored and adhered to. So this is the way we look at it. ARNI or ACE inhibitor or ARB, beta blocker, mineralocorticoid receptor antagonist, SGLT2 inhibitors. And you can see the various phenotypes. So it depends upon what are the parameters we look at. We look at the renal function, we look at the electrolyte, sodium, potassium, we look at the heart rate, we look at the blood pressure. So based on this, there are various phenotypes like patients with normal blood pressure, normal heart rate, who can tolerate the drugs in a better way. Those patients with good blood pressure, a lower heart rate, they tolerate most of the other drugs except the beta blockers. So based on these things, you can see how we can adjust the dose of this drug, how we can titrate or add these drugs. If the patient develops atrial fibrillation, then an anticoagulation can be added. If the rate is not controlled, that is again a role for digoxin. Then other drugs like hydralazine and isosorbate mononitrate. So basically it's only one thing. As early as possible, as many disease modifying agents as possible, and the 4 most important disease modifying agents are the pillars of therapy. So it is rapid evidence-based sequencing of foundational drugs for heart failure and a reduced ejection fraction. Previously it was ACE inhibitor, step up the ACE inhibitor, maximum tolerable dose, add beta blocker, step up, add mineralocorticoid receptor antagonist, step up, convert or change over to angiotensin receptor inhibitor. It will take at least 6 months for all the 4 drugs to be on board and reach the target drug or target dosage. By that time, you will lose precious time to prevent a mortality or heart failure hospitalization. The proposed new sequencing, beta blockers, which produce maximum reduction in mortality, early reduction in mortality, reduction in sudden cardiac death. SGLT2 inhibitors, well tolerated drugs. The beginning dose or starting dose is equivalent to that of the target dose. Then if you can have a little interval if needed can be given, and you can stagger angiotensin receptor blocker with this combination and add on angiotensin receptor neprilysin inhibitor, then mineralocorticoid receptor antagonist. And there are benefits of these drugs when started together. For example, when you combine beta blocker and ARNI, better tolerated mineralocorticoid receptor antagonist, the potassium level may not rise if an SGLT2 inhibitor is also added. So if the 3 drugs like beta blocker, SGLT2 inhibitor, ARNI, mineralocorticoid receptor antagonist may be better tolerated. So I must say, currently the fantastic 7 drugs of therapy in heart failure and reduced ejection fraction. RAS inhibitors, beta blockers, mineralocorticoid receptor antagonists, the SGLT2 inhibitors. Then the three drugs, vericiguat, omecamtiv mecarbil, and ivabradine. So this is the rapidly evolving heart failure and reduced ejection fraction therapy in 2022. The four pillars of therapy: beta blocker, SGLT2 inhibitor, ARNI, mineralocorticoid receptor antagonist. And if the patient cannot tolerate, or if the patient has renal dysfunction, ARNI or a RAS inhibitor can be shifted to hydrolysine nitrate. If the patient is symptomatic despite RAS inhibitors maximum tolerated dose, and if the blood pressure permits, hydrolysine nitrate may be added. Anticoagulant, if there is atrial fibrillation or LA or LV thrombus, digital is to control the heart rate in atrial fibrillation. And if the atrial fibrillation is troublesome with a high rate and if the drugs cannot control the rate or cannot change it over to sinus rhythm, then pulmonary vein isolation. CRT, if there is LBBB and wide QRS, and if the patient, despite the use of maximum tolerated dose of beta blocker, if the in sinus rhythm the heart rate is more than 70, add ivabradine. Pulmonary venous congestion or systemic venous congestion, further use of loop diuretic. If there is a diuretic failure, thiazide diuretic. And symptoms, despite the four major drugs, we may consider the use of vericiguat, right now not available in India. Omecamtiv, it is still not available. And if the patient is not improving, then it's a situation where you may have to think about a LVAD as either a destination therapy or a bridging therapy, and then finally the patient may go for a heart transplantation. Significant mitral regurgitation, now it is secondary mitral regurgitation, we may go for a mitral edge-to-edge repair. So this complete whatever therapy is available, medical as well as interventional therapy for heart failure and reduced ejection fraction. But what is happening in reality, you can see these three drugs, the basic drugs, RAS inhibitors, beta blockers, aldosterone antagonists, not 100% is receiving it. This in the getting with guideline therapy, you can see at the time of discharge, ACE inhibitors close to 90%, beta blockers close to 90%, aldosterone antagonists less than 50%. But if the patient is on these drugs, beta blockers, quite significant difference between the patient on beta blocker and patients not on beta blocker, or patients in whom beta blocker was withdrawn during hospitalization. Significant difference in the mortality for the same case for ACE inhibitor or ARB. Then in reality, what is happening in Kerala, the Cardiological Society of India, Kerala Acute Heart Failure Registry, you can see only 28% of the patient with heart failure and reduced ejection fraction receives guideline recommended medical therapy. The Trivandrum Heart Failure Registry, only 25% were receiving it. So that is the crux of the problem. It is not that fact that we do not know which are the heart failure medications, which are the drugs that improve the mortality, which are the drugs that reduces the morbidity. The problem is to use it. We are not using it. And you can see the graph. If we don't use a heart failure therapy, if you don't use the guideline recommended medications or disease modifying medications, it means we are killing the patients. We are losing the quite big opportunity or golden opportunity to prevent a death or prevent a heart failure hospitalization. So the viewpoint in 2022 is simultaneous or rapid sequence initiation of quadruple medical therapy for heart failure, optimizing therapy with the speed. Can see ARNI, day 1, beta blocker, initiate at a low dose if the pulmonary venous congestion or systemic venous congestion and the blood pressure permits. Mineralocorticoid receptor antagonist, usually no problem. You can initiate it at a lower dose. The hemodynamics may not be an issue. SGLT2 inhibitor, straight away initiated unless there is severe renal failure where it is not going to be of much benefit, or hypovolemia where the problem can be produced by SGLT2 inhibitors. It can be started. Most of the patients admitted with heart failure and reduced ejection fraction before discharge. So first follow-up, day 7, an early follow-up is important for adding medication or up-titration of medication, and there is data which shows that an early follow-up for following a heart failure hospitalization for acute decompensated heart failure improves the outcome. So within a month's time, maintenance or additional titration of the 4 foundational therapies. So current concept is in a month's time, if possibly at the time of discharge, the patient should be on all 4 medications, but at least in 1 month, a decent dose of all 4 foundational therapies should be on board in a patient with heart failure and reduced ejection fraction. So among patients hospitalized for heart failure and reduced ejection fraction and eligible for therapy, Differing initiation of life-saving medication to the outpatient setting carries a greater than 75% chance of therapy will not be started within the next year. So when the patient is discharged, they should be on the most important life-saving medications. If you don't start it, the patient may die, the patient may develop the heart failure hospitalization, which increases or which makes the situation more worse. Sometimes the patient may not get this drug at all in the next 1 year. So ARNI, ACE inhibitor or ARB, beta blocker, MRA, SGLT2 inhibitor, simultaneous or rapid sequence initiation of quadruple medical therapy for heart failure with the speed. These are 2 patients whom I saw in my clinic today who were, you can see 25th Jan 2022. The prescriptions, patient with anterior wall MI, post-PTCI, LV dysfunction, heart failure with reduced ejection fraction, normal serum creatinine, normal potassium, 200 milligram twice a day of ARNI, 10 milligram of bisoprolol. The heart rate was not controlled, so he's on 10 milligram of ivabradine, 50 milligram of aldosterone antagonist, 10 milligram of dapagliflozin, and with other drugs. And this is ischemic heart disease. Non-ischemic dilated cardiomyopathy, 10 milligram of bisoprolol, 15 milligram of ivabradine, 200 milligram twice a day of ARNI, and 50 milligram of aldactone with other drugs. So it is possible, and this must be the prescription for patients with heart failure and reduced ejection fraction. So let me conclude with this quote: knowledge is in the power until it is applied, and knowledge is useless without consistent application. And this is no more true than in any other, in this condition called heart failure and reduced ejection fraction, which is much more dreadful than a malignancy. Thank you so much.
Thank you, Jabir, for that excellent talk, for taking us through the evolution of pharmacological management in the last 2 decades. You so beautifully enlightened the emerging role of ARNI and the other important drugs like SGLT2 inhibition, beta blocker, and MRA. And you also very nicely stressed on the importance of starting these 4 drugs in quick time and not one after the other. It used to be the sequential therapy in the recent past. So diagnose early in the course of the disease, use the opportunity when the patient is admitted with decompensation, start these 4 drugs as early as possible. As you very correctly said, the opportunity to start these drugs is at the time of discharge, not during follow-up. The inertia even becomes more, not only at the physician level, but also from the patient's point of view. So the golden opportunity is to start these drugs when the patients are discharged after initial hospitalization. So I'm sure there will be a lot of questions. If the participants can quickly type in their questions in the chat box, for the next 5 minutes, we can have some quick discussion, because the next topic is completely different from this. So we can finish off the discussion on this topic in the next 5 minutes. We are really running short of time. If anybody has any pressing question, you can please ask in the chat box.
Nadraj, Praveen has joined.
Yeah, I thought Praveen can do the next session. Jabir, in the Indian context, what about the cost impact? These 4 drugs, particularly ARNI and SGLT2 inhibition, they are quite expensive drugs, and these are chronic conditions. So there is definitely an economic impact. So a lot of people think that you can give SGLT2 and you can give enalapril instead of something like a poor man's combination, one ACE inhibitor and SGLT2 inhibition. But you rightly emphasize the importance of ARNI plus SGLT2 inhibition.
Nadraj, you hit the bullseye. Look, I think I may consider it something, I call it as pocket toxicity of the medication. So apart from the pharmacological toxicity, this is the pocket toxicity, but there is some light at the end of the tunnel. When I started using this drug in 2015 or 16, I hardly had a couple of patients in 1 year. But now the number of patients on whom we are giving ARNI as well as SGLT2 is on increase, especially SGLT2 inhibitors, because of the current availability of generic SGLT2 inhibitors, which cost only 15 rupees. And the ARNI, that it's a problem. It costs around 3,000 or 4,000 additional rupees per month therapy. But if this can avoid 1 or 2 hospitalization, that is beneficial. that is truly beneficial. So I compare it with, and I discuss with the patients, and I'll tell them that this can avoid a hospitalization, which is quite expensive. And each hospitalization will cost at least the amount which is required to take this drug for at least 3 years or at least 2 years. But of course, I fully agree with you. Whatever all said and done, there are a lot of people who cannot generate this money for a month's drug. When they develop serious problem, they may get hospitalized, somehow they'll find money to give the hospital bill. But at the same time, electively, they may find it extremely difficult. But in that case, what I prefer is, it's always better to be in a guideline recommended medication, a cheaper medication like ACE inhibitor or a cheaper ARB like losartan potassium, rather than thinking about ARNI and not taking ARNI. It's always better, as you rightly pointed, it's always better to have a cheaper drug which is evidence-based rather than going for an additional advantage with a costly drug which he is unlikely to take. And another problem is our population, if we give a costly drug twice a day, they may take it only once a day. So here the SGLT2 inhibitors have got an advantage. They have, it has to be given only once a day. So I'll prefer a beta blocker, a cheaper beta blocker, a mineralocorticoid receptor antagonist, spironolactone if tolerated, it is also cheaper, a ACE inhibitor or a losartan potassium, and a generic SGLT2 inhibitor.
It's a very pertinent point that you mentioned. So, but then if you talk to physicians, they will say that they will say when the patients come to cardiology in the healthcare center, they may be able to afford these drugs. So what you said is an important message also for the physician community. When there is a way to start these drugs, we, at least physicians, should shed the inertia. In addition to the patients having problems with economy, etc., a lot of physicians themselves have when I say physicians, it also includes cardiologists. We also have inertia. We'll give 1 of the 4, we will give 2 out of the 4, etc. So Jabir's talk really opened a lot of eyes as to the importance of starting these 4 agents if and when possible. You should find every excuse to start these medications rather than finding reasons not to start these medications. So with that, I will close this talk. Excellent talk as usual, Jabir. I really enjoyed. I wish I was there directly with you in that hall.
Praveed wanted to ask something. Nataraj, can we have a question from Praveed?
Nothing, sir. It was an excellent talk. One, I just wanted to ask a question. Is it a norm that you showed 200 milligram BD? Is it the majority of your patients, or most patients we are unable to reach this?
I fully agree with you. I looked into my data. 24% had 200 twice a day.
Okay.
75% it is 100 or 50 twice a day.
They don't have a rise in creatinine over like 6
No,
months.
these people 200 milligram. And one more thing, one interesting thing from the data as well as this thing I found is that those patients who tolerates this drug well, I think they may be having a less severe heart failure symptomatically. Those patients who cannot tolerate this drug, very severe heart failure, and their mortality is also high. So that is one problem with these trials. So patients who tolerate a higher dose, they do well because I think they are destined to do well. Patient who cannot tolerate.
Because some people just like beta blocker variability among patients. The receptors may be variable. Neprilyzing receptors might be different in different populations.
Can you keep the mic closer to you, Praveen?
Yeah. Sometimes it might be also that neprilyzing receptors in the body might be so variable. So people who have high neprilyzing levels or neprilyzing receptors in the body might be responding more.
Or perhaps
with a lower dose.
Perhaps their heart failure is so bad that most important obstacle or hurdle I have seen is a low blood pressure.
Yeah, probably it is those patients who have higher neprilyzing receptors.
Maybe.
So
I'm not sure
they'll
about
be
it.
just even if you give 50 milligram, they'll have a low BP. Everything suddenly.
They cannot tolerate even 50 milligram. They develop postural hypotension. So I have a couple of patients who are only on half tablet twice a day. But I feel that it's better to have a smaller doses. There is some data also. Better to have some dose of drug rather than having no drug.
Second question is regarding glyphosate. Endocrinologists often stop even when we start it.
Yeah,
they
absolutely.
come and just stop.
I fully agree with you. So nowadays, what I always tell the patient is, this drug is not for your sure. This drug is for your heart and is for your kidney. You tell the patient it will protect your kidney. He will not stop that drug till he dies. Okay. So now always I tell, if somebody else asks you to stop this drug, you tell him that unless and until there is a contraindication, better not to stop this drug. This is not for the control of your diabetes. This is for your heart and kidney. That is the only way, because I also found this problem. Whenever we start this drug, after 1 month they came back, he told that this drug, there is no need to take this drug.
I mean, we'll continue the discussion later. We are running short of time. So,
Okay, Nataraj, thank you so much.
Thank you very much, Jabir, for that excellent talk. So now the next talk is on a very important topic, though it is not something to do with heart failure. It is to risk stratify patients with Brugada syndrome pattern in the ECG. It's a very pertinent topic, and I'm very happy that Ajit is going to speak on this very good topic, because more than symptomatic Brugada, let's say somebody has a type 1 Brugada pattern who had a syncope, which is most likely rhythmic syncope, things become easy. You know that this is at high risk, and you can recommend something like an ICD for secondary prophylaxis. The problem comes when somebody has a type 1 Brugada pattern, which was incidentally picked up during comprehensive checkup or a pre-placement examination, and this person never had symptoms in life. That is when we are having this confusion as to how to risk stratify this patient. And we have an eminent electrophysiologist, my good friend Dr. Ajit, who will enlighten us on how to approach a patient who presents with a type 1 Brugada syndrome pattern in the ECG, either with symptoms or without symptoms, how he will proceed to investigate such a patient. Over to you, Ajit.
Thank you, Dr. Natarajan. So, at the outset, as you know, I can't answer many of those questions because nobody knows the answer to those questions, but we will see what data we have. So let's get started. So I'll talk about 4 things. One is, how exactly are we supposed to go about diagnosing Brugada syndrome? What is the role of some of the provocative tests which are available? And how do you manage the asymptomatic patient, which is a big problematic one? And some controversies are managing the symptomatic ones. So first up, diagnosis. Now, Brugada syndrome is typically diagnosed based on the type 1 ECG pattern, which is a 2 millimeter J point elevation in this is wrong. It's not V1 to V3. It's only V1 to V2. I'm sorry, it's an old slide. Right now, we only look at V1 to V2. We no longer look at V3. So it's a 2 millimeter J point elevation in at least one lead among V1 or V2. I should say that it's one lead among V1 or V2. It's important to note that there are different types of Brugada patterns. The typical one we know is the type 1 or the Cout pattern. There's a type 2 and a type 3 pattern, neither of which is diagnostic. Both have a saddleback T wave, and the type 2 has a greater ST elevation at the nadir of the T wave, and the type 3 has a smaller ST elevation at the nadir of the T wave. Neither of them are diagnostic. We should also make sure that we do not confuse Brugada pattern with right bundle branch block. The simplest way to look at that is, in Brugada pattern, we will not have the QRS and ST segment angle or the STT angle. RBBB also, sometimes we may not see the angles, but if we do see this angle and this angle, it's not the Brugada pattern. Now, the diagnosis of Brugada syndrome used to be simple till recently. This was the accepted criteria for diagnosis. You have a type 1 ST elevation of at least 2 millimeters in at least one lead out of V1 or V2. Now, V1 and V2 may be positioned as usual in the fourth space or the third space or the second space, because the abnormalities in Brugada syndrome occur in the RVOT, and the fourth space is only the lower part of the RVOT. So V1 or V2 positioned in this fourth, third or second space, spontaneously or after an IV provocative drug test. That is the original definition. So either spontaneous or after an IV provocative drug test. But later on, a group of experts joined together in Shanghai in 2016 and said that maybe this diagnostic criteria needs changing. And they said that, okay, if anybody has a spontaneous type 1 Brugada pattern at nominal or high leads means third space or second space, that's it. It's a diagnosis of Brugada pattern. It's a diagnosis of Brugada syndrome. A spontaneous type 1 Brugada pattern diagnoses Brugada syndrome. They also said that if it is not a spontaneous type 1 pattern, for example, a type 2 or type 3 can convert to type 1 during fever or during certain drugs, they said that that is not enough to call this a Brugada syndrome. It still remains only a pattern. So if somebody has a non-spontaneous type 1 pattern or only a type 2, type 3 pattern, they said you need some more of these things. Either the unexplained cardiac arrest, clinical history, basically clinical history suggestive of unexplained aborted sudden cardiac death, or a family history in a first or a second degree relative with definite Brugada syndrome. The rest of them carry only very little amount of points, and genetic test, as you can see, has only 0.5 as a score. Now coming to the provocative test, which both of these allude to. So there are two diagnosis criteria which you can use. It depends on you which criteria you want to use. Well, I usually use the first criterion, but there is no head-to-head comparison of which of these criteria should be used, whether you should use the Shanghai score or the criterion recommended by all the societies. Now, coming to the provocative test that both these scores refer to, or these criteria refer to, the IV provocative test, there are three types of IV drugs which can be used to provoke Brugada syndrome. That's ajmalin, flecainide, or procainamide, or a single dose of oral flecainide 400 mg can be used. And the ECG lead position during provocative test should be the V1, V2, V3, V4, V5, V6 placed in the fourth, third, and second intercostal space parasternally. There is no role for ECGs beyond the V2, the V3, V4, V5, V6 standard position. There is no role for diagnosing Brugada syndrome either spontaneously or during provocative test. Now coming to the IV provocative test, the methodology for the IV provocative test was very well validated. You could not have a better validation. What they did was they got 58 patients with type 1 Brugada pattern with a ventricular fibrillation or aborted sudden cardiac death, which means the diagnosis was never in doubt. These patients had spontaneous type 1 pattern and VF or aborted sudden cardiac death. And 34 of these 58 patients, the type 1 pattern disappeared at follow-up. 24 of the 58 patients, the type 1 pattern remained at follow-up. Now, they took these 34 patients where the type 1 pattern disappeared at follow-up, and they gave these provocative drugs, and they were able to reproduce the type 1 pattern on drug testing in 100% of the patients. As a control group, they took 53 patients who did not have type 1 pattern recorded at any time and did not have a history of VF or sudden death, and did a drug provocative test, and they could not get this type 1 pattern in 100% of them. They could not get this type 1 pattern in 100% of them. And of note, I have not written here, none of these patients had a VF or a sudden death at follow-up. The follow-up was 40 months, 28 to 40 months. So I think the methodology for the IV provocative test is rather foolproof. So I'd rather believe with them when they say that the sensitivity and specificity are virtually close to 100% for the IV provocative test. Now, as you all know, we do not have any of these three drugs in India and in many countries. Ajmalin or flecainide or procainamide are not available in the IV form. So we use the oral provocative test. What we do is a 400 milligram single dose. So this is a case example. This is a 44-year-old male who had no known diseases, had a sudden collapse with agonal respiration, tonic posturing, and bladder incontinence. Bystander gave CPR, continued to give CPR till they reached the hospital within 20 minutes. At arrival in the hospital, he was in sinus rhythm, but he was unconscious, and he became conscious spontaneously after 30 minutes. He had no recollection of events. The whole event sounds like an aborted sudden death. Echo was normal, troponin was normal, blood investigations were normal. This was his ECG. His ECG is completely unremarkable. So he goes for a provocative test, and this is the provocative test before the flecainide. Okay, so here the ECG, V1, V2 are kept in the fourth intercostal space. V3 and V4 are kept in the third intercostal space. V5 and V6 are kept in the second intercostal space. This is before flecainide. This is 1 hour before, 1 hour after flecainide. Hardly any changes. 2 hours after flecainide, some subtle changes have begun to appear in the second intercostal space here. Maybe subtle changes in the third intercostal space also. No changes in the standard fourth intercostal space. 3 hours after flecainide, the changes in the second intercostal space become a little more obvious. 4 hours after flecainide, there is absolutely no doubt when we look at the ECGs in the second intercostal space. These two are the second intercostal space. There is fairly clear evidence in the third intercostal space also. The fourth intercostal space remains normal. 5 hours, absolutely no doubt, except in the fourth intercostal space, still it's not diagnostic. 6 hours, once again, absolutely no doubt, if you look at the second and the third intercostal spaces. And at 9 hours, the pattern reversed. And he was diagnosed as having a Brugada syndrome based on history suggestive of aborted sudden cardiac death and a provocable type 1 ECG. This would make a diagnosis in both those criteria, whether you use the Shanghai score or whether you use the society's definition, the HRS or EHRA or APHR definition, it would still diagnose Brugada. And he was implanted with an ICD, and the decision turned out to be right, because 8 months post ICD, he had an episode of ventricular fibrillation, and the ICD saved him. This is the talk given by the ICD. Now, the oral flecainide challenge usually becomes positive within 2 to 3 hours, and usually the changes resolve within 5 to 7 hours. It must be done only with a defibrillator patch stuck onto the patient in an ICU with a resuscitation facility standby. The problem with the oral flecainide challenge is the methodology has not been studied in as proper a manner as the IV provocative test. So this is the largest matter available, the largest material available on the oral flecainide challenge. This is from Srijitra. What they did was, they took patients with family history of Brugada syndrome or a history of suspected arrhythmic syncope or an unexplained ventricular tachycardia, and therefore they suspected Brugada pattern. Of course, none of them had a spontaneous type 1 Brugada. If they had a spontaneous type 1 Brugada, they would be diagnosed as Brugada. They did not have a spontaneous type 1 Brugada. They collected 32 such patients, of whom 29 underwent a flecainide challenge test, single tablet of 400 milligram. Of which 13 had type 2 or type 3 pattern. 16 had no pattern suggestive of Brugada. There was a 55% positivity of the test. The test had 55% of them returned a positive test, meaning 55% of them converted to type 1 pattern. The problem here is there is no follow-up available. They'd also given 4 patients had received IV flecainide, and the other 25 had received oral flecainide. Now, the patients who received IV flecainide did not get an oral flecainide. So this is not a comparison between IV flecainide and oral flecainide. Out of the 4 who received IV flecainide, 2 had a positive test, meaning 50% positivity. Out of the 25 who received oral flecainide, 13 had positive, meaning 55% positivity. Unfortunately, there is no follow-up available for this, which means that we do not know if those patients who had a positive conversion to a type 1 pattern had events at follow-up. So, we do not know whether the ones who did not have a type 1 pattern, meaning the ones who had a negative pattern, did not have events at follow-up. So this study actually takes off from this particular study. This was the first study to evaluate oral flecainide to unmask type 1 Brugada pattern. So here the inclusion criteria was similar: a family history of Brugada syndrome or a suspected arrhythmic syncope. They had only 14 patients. They had once again a 50% positivity, meaning 50% converted from a non-type 1 pattern or a non-Brugada pattern to a type 1 pattern. And only two of them had an ICD. The indication for ICD at that time in that particular study group was a positive flecainide challenge plus inducible VT or VF and EP study. They had 19-month follow-up. None of the 14 patients had any events. So once again, I conclude that the sense, neither the specificity nor the sensitivity of an oral flecainide challenge test is known. We just do not know. So who should undergo a provocative testing for Brugada syndrome? In one word, there is no answer in the literature. This is what the approach that I use. Those patients where the diagnosis of Brugada syndrome will affect the treatment undergo a provocative test. Those patients where the diagnosis will not affect the treatment will not undergo a provocative test. For example, I discuss with them in advance. If your provocative test returns a type 1 pattern, are you going to opt for an ICD? If the provocative test is going to return a type 1 pattern and they're going to opt for an ICD, then it makes sense. At least logically, to me, it makes sense to do a provocative test. If not, it doesn't make sense to do a provocative test with oral flecainide. because we just do not know the sensitivity and specificity of this. So my indication for oral provocative test, and that's the only test that we have, is syncope suspicious of aborted sudden death and ECG not showing a type 1 Brugada pattern. So let's take this particular example. A 64-year-old male with 3 episodes of syncope. I will not read through the whole thing, except saying that all the 3 episodes could very well have been vasovagal syncope, going by the history. And I wouldn't do and this patient had a type 2 Brugada pattern on ECG. This patient had a type 2 Brugada pattern on ECG. I wouldn't do a provocative testing on it, because if I did a provocative testing on him, it is going to only add to the confusion. He does not have this is basically, I will just uncover, at best, I might uncover inducible type 1 pattern in a patient with nothing else. So I definitely would not do a provocative testing in a patient who does not have a history which is suggestive of aborted sudden death. So now in this particular patient, I would either do a tilt test or reassure the patient saying that, okay, this is fine. It just sounds like vasovagal syncope. Please take measures for vasovagal syncope. The problem occurs when the sister of the patient died of Brugada syndrome. In that case, I gently tell them, okay, we will do a provocative test if we find a Brugada syndrome in you and you accept an ICD, even though the guidelines do not really recommend that. But it's impossible to, logically speaking, it's impossible to convince when this patient, so I'm talking about another patient, she was a 30-year-old staff nurse. Her sister, who was just 32 years old, just 2 years older than her, they were, virtually grew up together. Both of them were nurses. Her sister, after a long struggle, got a good job in Australia. And 1 year after she got her job, she was the one actually who was taking care of the family finances, because she was finally managed to get a job. And this girl's dream was also to migrate to Australia and get a job. 1 year after reaching there, she had sudden death due to Brugada. Despite the best resuscitative efforts, she could not be resuscitated. Now, this particular patient whose sister died, this patient has a type 2 Brugada pattern. Now, all guidelines would say that if you induce a type 1 pattern in this condition, you do not put an ICD, but definitely this patient is not going to take it. The only question this patient wanted to ask me was, okay, I'm pregnant right now. Do you think I should put the ICD during my pregnancy, or do you think I should wait for the pregnancy to get over without putting the ICD? There is, obviously, if somebody has gone through that, where a sibling has died due to Brugada syndrome, and you have a type 1 Brugada syndrome, even though the guidelines don't say that, even though there is no evidence to say that family history by itself is not suggestive, when all our stratification methods have their own drawbacks. So finally, the decision goes back to the patient. So now I come to this really vexing part: management of asymptomatic Brugada syndrome. So here is the problem. Approximately 1% of people with spontaneous type 1 pattern carry a risk of sudden death. 99% of the patients do not have a risk of sudden death. Sudden death is usually the first manifestation of Brugada syndrome, and it's usually due to ventricular fibrillation. Ventricular fibrillation and sudden death usually occur during vagotonia. Some patients may be lucky enough to have a nocturnal agonal respiration before sudden death occurs, but most of those patients who are going to die suddenly just die suddenly without any indication before that. And unfortunately, only 1% of people with spontaneous type 1 pattern carry this risk of sudden death. Now, how do you separate out this 1% who has this risk of sudden death from the 99% who do not have this risk of sudden death? That is the big problem. And the problem is exacerbated by the fact that the only proven therapy is ICD. Quinidine is a drug which may or may not work. Nearly a decade back, they tried to start a randomized controlled trial on quinidine. It never took off. So we still do not know whether quinidine can be used for this indication for primary prevention of sudden death. Radiofrequency ablation, the abnormal part of the RVOT, is an option, but it may be an overkill to go and do it. So really the only proven therapy is an ICD. So how do you figure out which 1% of the spontaneous type 1 needs an ICD and which 99% of the spontaneous type 1 do not need an ICD? So they first started looking at the Shanghai score. Can the Shanghai score be also prognostic to decide ICD requirement. So this is basically what they said. They said, look at the score and look at the point score. They said that if the point score is less than or equal to 3, meaning you never ever get a spontaneous type 1 pattern, or you do not get a nocturnal sudden death history and a type 2 pattern, then your event rate is 0. So that I think almost everybody will agree that if you never ever document a type 1 pattern and you do not have a nocturnal sudden death history plus a type 2 pattern, then I think even without going through the score, I think most of us know that they're not going to have a sudden death. So, but this is where the Shanghai score seemed attractive. They said as the score goes up, the yearly chance of sudden death, the 10-year event rate goes up, so much so that once the score is 5.5, they said that the 10-year event rate is 25%. So they recommended an ICD to anybody with a score of 3.5 or more, essentially anybody with a spontaneous type 1 pattern. So that's basically what they said. Now, that is a little difficult to stomach because a huge number of patients have a spontaneous type 1 pattern. Remember, a Shanghai score of 3.5 just needs a spontaneous type 1 pattern. That's it. So that becomes a little difficult, even though this is what they recommend. So now there was, and this is not the only score. Some other groups of people looked at another score called the Sierra score. Now, these are all very large, done on very large patient cohorts. A 400 patient derivation cohort and a 150 patient validation cohort and an 80-month follow-up. And they came up with this probability of the survival probability. They said that at 0 or 1 point, so these are the points they considered: a spontaneous type 1 pattern, familial sudden cardiac death less than 40 years of age, an inducible VTBF on EP study, syncope, sinus node dysfunction, or a history suggestive of aborted sudden death. And they gave points to all of these. And they totaled up all these points. And they said that this is the chance of sudden death. This is the chance of sudden death at 2.5 years, 5 years, 7.5 years, and 10 years. So if you just look at the 2.5-year cutoff value, you can say that if you have a 2-point score, the survival probability is extremely high. They said that their final recommendation is that if your score goes up to 3 or more than 3, then you suggest an ICD to that patient, because the survival at 2.5 years, the survival probability is about 85%, which is about 15% mortality at 2.5, which is pretty high. So this is what all of the, and they also look at what is the 1-year probability, 5-year probability, 10-year probability. So their cutoff was basically what I told, a score of 3. They said a score of 3 distinguished somebody with a 1-year survival of 97% and a 1-year survival of 89%. That seemed to be the good score, the score of 3. Now, there was an independent analysis of both the Shanghai score and the Sierra score on a third patient subset. Now, a huge number of patient subsets of Brugada are available because the data is being kept in many registries all over the world. So the moment a score comes, the score is gone and applied to some other registry. So the probes applied this both the Shanghai score and the Sierra score to a third independent European registry and looked at what is the validity of these scores. And well, unfortunately for everybody who was expecting something useful, found that when a patient was asymptomatic, neither the Shanghai score nor the Sierra score, okay, the Shanghai score is in dotted lines, the Sierra score is in bold lines. They said that when the patient was asymptomatic, neither the Shanghai score nor the Sierra score had a great predictive value. The area under the curve was just above 50%, meaning it was just something like flipping a coin, slightly better than flipping a coin. If a patient had syncope, both of them had an area under the curve somewhere around 60%, still not great. And the patient had aborted sudden death, both of them had an area under the curve approaching 90%, which of course we all know. So finally it came back to what we knew. If you have, so they finally concluded that when both the scores were independently evaluated on a third cohort, they finally came back to the original conclusion. Unless you have syncope, these scores don't seem to help. So it didn't stop there. Yet another score came out. So these are the score is an European score from these European countries. It's called the Brugada risk score. They looked at all of these criteria: age, sex, probable arrhythmic syncope, family, sudden death. Now, I made some comments across 4 of these criteria, because there were 1,110 patients in this registry. Out of the 1,110, only 731 were screened for a mutation. So straight away, the validity of finding a positive mutation or a negative mutation goes down. Now, the programmed extra stimulation is worse. Out of 1,110, only 406 underwent a programmed extra stimulation. So then again, whatever this registry is going to talk about programmed extra stimulation must be taken with a huge lump of salt. Out of 1,110, only 436 looked at a ventricular extra effective refractory period less than 200 milliseconds, which is another parameter looked at in EP study. So once again, if this registry is going to talk anything about the role of EP study, it must be taken with a big lump of salt, because only less than 50% actually underwent that test. So whatever this registry is going to say about SCN5A mutation, or the role of inducible VTVF, or the role of VERP less than 200 milliseconds in EP study, I will definitely take it with a big lump of salt. So let's come back to what the score said. They also came up with some new signs called the AVR sign, saying that if you have an R more than 3 millimeter in AVR, is a dangerous part. And they also came up with a new thing called the peripheral Brugada pattern. That is, you find a typical Brugada pattern in at least one limb lead, in addition to finding it in the chest lead. So they came up with these 3 new things. And they also came up with a new ECG criteria saying that if you have early repolarization pattern in at least 2 inferior leads or 2 lateral leads, in addition to Brugada pattern, they said these are high risk scores. And they also said that if there's a fractionated QRS defined by at least 2 spikes in V1, here you can see there is 1 spike here and 1 spike here. So 3 spikes, 1, 2, 3. If you take this also as a spike, this is 3 spikes in V1. Or 4 spikes in V1 or V2 or V3. So these are the additional things that they looked at. And they also came up with a score. Now, this is pretty recent. This was published in 2021, in mid-2021. And they said that as the score goes up, the risk goes up. They said that out of all these things analyzed, only these 4 things really added up to the score. That is a spontaneous type 1 pattern and a syncope suggestive of aborted sudden death. These 2 are things which we already know carry a high risk. A spontaneous type 1 pattern and a syncope suggestive of aborted sudden death. They said that out of the other things analyzed, also a peripheral lead type 1 ECG and a peripheral lead early repolarization will also be prognostic. But like I said, I will not really buy the data regarding genetic analysis or programmed extra stimulation or ventricular extra refractory period determination from this registry for the previously mentioned issues. So they said that in addition to these 2 well-known factors, these 2 factors also would be prognostic. And they did not recommend an ICD or non-recommend an ICD. But what they said is that roughly once the 5-year predicted risk of sudden death starts going up to about 15%, once his score is about crosses 15%, the 5-year risk of sudden death goes to about close to 10%, which is roughly where the ICD cutoffs go in the recommendations. Now, once again, I will not really believe any of these scores unless they are validated on a separate cohort. With time, these scores will be validated on separate cohorts. Till then, I would take all of these scores with a pinch of salt, because once we find, it is very common to find that a score is validated in a separate cohort and suddenly you find a totally new finding. So I'll still wait. I'll say that, okay, maybe this is there. Now, what about VTVF? What about the role of EP study in Brugada syndrome? Now, this is the pooled analysis of all the studies which did EP study. There were a total of 1,312 patients who underwent inducibility for ventricular tachycardia, ventricular fibrillation. It mostly comes from these registries, the finger Brugada registry and the prelude Brugada registry. These are the 2 registries which did a maximum number of patients for inducible VTVF. And I would take your attention to this table, which came from the pooled analysis of EP study. So they looked at what is the value of inducible. So this is where we really want the answer. Okay, a spontaneous type 1 ECG pattern and the overall number of events is 1.04%. Okay, yearly event rate, yearly sudden death rate is 1.1% or 1.04% in a spontaneous type 1 ECG pattern. In that spontaneous type 1 ECG pattern, if you induce a VT or a VF, the yearly risk goes up to 1.7%. That's good. The problem is here. If you return a negative EP study, if you do not induce a VT or a VF, the yearly sudden death risk stays at 0.78%, which is roughly 0.8%. And if you look at an induced type 1 pattern, a drug-induced type 1 pattern, okay, a drug-induced type 1 pattern, the discriminatory value is extremely low for an EP study. The overall yearly event rate in a drug-induced type 1 pattern is 0.27%. A positive EP study with a drug-induced type 1 pattern is 0.45%, and a negative EP study with a drug-induced type 1 pattern is 0.23%. So the absolute number, now if you take the hazard ratio, it is great. The EP study, negative EP study versus positive EP study hazard ratio is more than 2. But if you look at the absolute numbers, it just makes absolutely no sense. And if you have a syncope at presentation, the event rates are 2.55 even if you have a negative EP study. So the negative EP study has no role if the patient has syncope. The EP study has no role if a patient has syncope, even if it is a drug-induced type 1 pattern, because the discriminatory value between a negative EP study and the positive EP study is poor. So this is what I would, if I have to do an EP study in a patient to look for VT-VF inducible, it's not that I don't do it, but if I have to do an EP study in a patient to look for Brugada syndrome, before doing the EP study, I ask the patient, look, if I tell you that you have, at the end of this test, if I tell you that you have a yearly change, that the test has changed your yearly mortality probability from 0.8% to 1.7%. Will that change your decision on whether to get an ICD or not to get an ICD? So far, I have found one patient. In 12 years, I've seen one patient who has said yes to this question. All the other patients, I must have asked this question to at least about 50 patients. One patient said it will change my outlook because I get reimbursed for the ICD if an EP study is positive. That's the reason he gave. The reason is because he cannot afford an ICD without reimbursement. And he said, if you have a positive EP study, I'll get reimbursement for an ICD. So and without a reimbursement, I can't afford an ICD. So for that reason, the change in mortality, a positive EP study will influence my outlook. All the other patients said, doc, it makes no sense. You're saying that if my EP study is negative, my chance of death is 0.8%. And you're saying that if it's positive, it's 1.7%. And you're saying that if I do nothing, it's 1%. You're talking about death. It makes no sense. So it absolutely makes no sense to me to do an EP study for VT-VF, given the poor discriminatory value in patients with or without syncope in patients with an EP study. So this is how I go about it. If a patient has a resuscitated VF, there's a 7% yearly. Now, remember, even in resuscitated VF, the event rate is only 7% per year. It's not like, everybody is resuscitated VF is going to get another VF. The event rates in Brugada are pretty low, but the problem is Brugada almost always affects otherwise young, healthy people in the 30s or 40s. So that is why when the events are catastrophic, it's not sick patients. So in resuscitated VF, the event rate is 7% per year. Syncope, suggestive aborted VF, and a spontaneous type 1 pattern is 3.2% per year. To me, that is good enough to suggest an ICD. Syncope with only a drug-induced type 1 pattern is 1.44% per year. So what I do is, if a patient has a resuscitated VF, I tell them put an ICD. If a patient has a syncope, suggestive aborted SCD, and a spontaneous type 1 pattern, I tell them put an ICD. These two subsets, I give them the actual numbers and I ask them, what do you want? What do you want? I give them the actual number. I tell them, look, I don't know. The event rates are somewhere about 1 to 1.5%. Whatever test I do or don't do, I cannot really tell you that you are at zero risk. There is no test to tell you that you are at zero risk. Your event rate, whatever test I do, will remain at 0.8%. And however positive, however highly positive the test is, your event rate will not go above 2%. You decide. So what I tell them is, if you can afford an ICD, you put an ICD. If you are worried about an ICD, and ICDs do have inappropriate shocks, the lead failure rates are about 2 to 5%. So those 2 to 5% will come with inappropriate shocks. I've had patients who have put an ICD simply for spontaneous type 1 Brugada, and they come back with 21 inappropriate shocks in a day, saying that, doc, I wish I never did this. So that also happens. So unfortunately, there is no easy answer to the question posed at the beginning of the talk. Which patients with spontaneous type 1 pattern without a history of syncope suggestive about a sudden death are likely to benefit from an ICD? Unfortunately, there is still no good answer to the question. What I tell these patients is, I tell them these absolute numbers and I sit down and talk with them and I go by their decision. If they ask me, what do you think? Do you think I should put an ICD? I said, I don't know. I really don't know. If you just have spontaneous type 1 ICD, type 1 ECG, you ask me whether you should put an ICD to reduce a 1% yearly risk of sudden death, and you put an ICD where you could get maybe about 2 to 5% lead failure rate, usually pressing at inappropriate shocks down the line at 7 or 8 years. I say, I don't know, because I don't know. I don't think anybody knows. We still don't know the answer. Now, other factors which have been found to be prognostic in limited studies are Brugada burden in 24-hour holter, the percentage of time in 24 hours that is spent in a type 1 pattern, post-exercise augmentation of type 1 pattern, a longer TP to T peak to T end interval, abnormal signal average, but none of them really have gone through rigorous analysis to put them into a predictive model. All we can say to spontaneous type 1 pattern patients, there is a list of drugs which you must avoid. And if you get fever, treat yourself promptly. Now, so here's the suggested management. This is a fairly good overview of how to manage. So electrical storm, we give isoproterenol. Prior cardiac arrest or sustained VT, we put an ICD. Syncope or presumably arrhythmic origin, we still put an ICD. Or close follow-up with or without ELR. I have no idea what close follow-up means, because usually the first event is death. So I really no idea what close follow-up means. I have tried to look at in ICD patients. If there is an ILR, it makes sort of sense, because what I observed in patients with Brugada who have received ICD for secondary prevention and who have received multiple shocks is that somehow just before multiple shocks, non-sustained VF starts clustering. At least I don't have large numbers of such patients. I probably have about 10 or 11 such patients on follow-up. But I see it at least in 50% of them, short runs of non-sustained ventricular fibrillation, short runs of non-sustained ventricular fibrillation comes up. And then one day they have sustained ventricular fibrillation and multiple shocks. So maybe if a patient wants to be on follow-up, I would put an implantable loop recorder. Otherwise, there is no meaning of close follow-up, because the first manifestation is usually death. So if a patient with syncope with presumably arrhythmic origin does not want an ICD, I would strongly counsel him at least put an ILR. But if you put an ILR, you must be on daily remote monitoring. There is no point putting an implantable remote monitoring and coming for 6 monthly follow-up or yearly follow-up. If you put an ILR, your ILR must be on daily remote monitoring, so that the moment you get non-sustained ventricular fibrillation, I know, and next day I call you and you should be ready for an ICD. Unless that is there is no point in using an ILR, and there is no such thing as close follow-up, because like I said, the first manifestation is death. Asymptomatic, spontaneous or type 1 pattern, again, close follow-up, a word with absolutely no meaning. Whether to give quinidine, nobody knows. Some people who are in favor of quinidine say quinidine if ICD is indicated but refused. Nobody really knows whether quinidine is going to work. That's the only drug which has been shown to work in vitro. In vivo, nobody knows. Type 1 pattern induced by sodium channel blocker, again, that vague thing, close follow-up, God knows what that means. repeated ICD appropriate shock. Well, quinidine, because that's the only one drug which is shown to work in vitro. In vivo, there is no real good data for any drug. Maybe RVOT ablation, maybe silestazole. Again, small numbers, quinine has been shown to work. Small numbers, silestazole has been shown to work. Now, coming briefly to the management of symptomatic Brugada, that is the patient who had recurrent events which you think is a Brugada. So here is a 65-year-old male who had recurrent presyncope during the daytime. And one night, wife found him unconscious in bed, and he had actually fallen off the bed. And the wife shook him and woke him up. And he said, I don't know what happened. There were multiple 2.5 second sinus pauses. And he was implanted with a dual chamber pacemaker elsewhere. Now, I find this history very suspicious because people with sinus node dysfunction do not fall unconscious in bed at night and roll off the bed and get woken up from the floor and say that I don't remember anything. He had 2 episodes of syncope, suggesting aborted sudden death 1 year later. And this was his ECG, sort of suspicious. And this was his interrogation of his pacemaker. He somehow survived this long an episode of rapid ventricular tachycardia. And he was upgraded to a dual chamber ICD because this original syncope was misconstrued as sinus node dysfunction, which should not have been, because sinus node dysfunction does not make you unconscious when you're lying down in bed at night and fall off the bed. He was upgraded to a dual chamber ICD because he also had sinus node dysfunction. Probably the daytime presyncope was due to sinus node dysfunction. He had multiple ICD shocks for VF. So he was taken up for ablation, and this is how the leads are placed. And you straight away go to the RVOT epicardium because usually that's where the substrate is. And generally you can find low voltage area. This red color is the low voltage areas. And you ablate all the low voltage area. The low voltage is found after giving flecainate. And you also find not just low voltage, but also long duration electrograms like this in the RVOT. You might also find discrete abnormal potentials in the RVOT. These are the electrograms I found in this patient, and this is exactly similar to the electrogram described in the original paper of RVOT ablation 2011 of 9 patients, where 9 patients with Brugada syndrome. This is signals that I found, and this is the signals that they found, where 9 patients with recurrent ICD shocks for Brugada underwent ablation, and the local electrogram was abolished. That was the endpoint of ablation. And 3 months post RFA, and even on long-term follow-up, 3 months post RFA, only 1 patient had a type 1 pattern, and no patient had ICD shocks at 29 months of follow-up. So seemed to be an excellent option. And this was from the patient that, the first patient that I'm alluding to. The type 1 pattern, well, it didn't completely disappear. From a 0.28 millivolt ST elevation, it went down to a 0.14 millivolt ST elevation. But 1 hour post RFA, it had normalized on a 12 lead ECG. So at that time, we looked at whatever ablations we had done. This was years back, I'm talking about in 2018. At that time, we put together data of 5 patients. And personally, I ablated 4 patients for recurrent ICD shocks, frequent ICD shocks. All had only epicardial ablation. And the results have been phenomenal. From 22 shocks, they went from 0.5 shocks a year, meaning from 22 shocks, they went to 0 shocks. And only 1 patient had a shock after RFA, and that too 4 years after RFA. And in that patient, type 1 pattern had recurred. I gave him quinidine. He did not have any shocks. I suggested him quinidine. Quinidine was not available. Gave him quinine. On quinine, he did not have shocks, but he had severe tinnitus. I had to stop quinine. So I don't know whether quinine worked or not. There have been reports that quinine will work in a small number of patients, but ablation did give a fantastic result in these patients. From, like I said, from 22 shocks in these patients, it went to 1 patient in 1 shock after 4 years. So somebody stop my screen sharing. Can I continue? What's happening here? Can you see my screen? I can't. Is my screen visible?
Yeah, your screen is visible here.
Okay, my screen is not visible to me.
Like, can you stop this? Can you route it? Can you switch it off? It's not moving there.
Can I restart again?
Yeah, I think you can stop share and
I'll
restart.
stop share and restart again. I'll share screen again. Okay, I've gone to share screen again. Okay, here. Okay, I think it's come back now. Has it come back? I can see it.
Yeah, we can see.
Okay, good. So it seems to be a great therapy. Now, if it is such a great therapy, why don't we ablate more patients with Brugada syndrome? The initial studies, ablation for Brugada syndrome, only include those with recurrent ICD shocks. Excellent results, fantastic results. Now, it's like close to 90-95% success. So people went one step further. From going from ablating for recurrent ICD shocks, they went to the concept of electrical substrate elimination in Brugada syndrome. That is, you don't need to have ICD shocks. You don't need to have VF. Just get type 1 pattern and eliminate the type 1 pattern. So here's the biggest study on that. 135 patients with ICD for Brugada syndrome. And that group, this is Peponi and Brugada together. Their indication was still spontaneous or inducible BTDF. RVOT epicardial RFA eliminated the local electrograms and normalized type 1 pattern in all the patients. There was only a 10-month follow-up, and no patient had any. That is too short a follow-up because the event rate in Brugada with resuscitated VF is 7%. So we still don't know. We don't know whether we should go to the extreme of ablating everybody with type 1 pattern. I stick to what I showed in that flow chart. Ablate those with recurrent ICD shocks. So to conclude, management of type 1 asymptomatic is unclear. Unfortunately, I cannot answer the question which was asked at the beginning of the talk, except avoid precipitating drugs, fever prompt. Drug provocation only if syncope is suggestive of ventricular arrhythmia, especially if it's an oral drug provocation, because the sensitivity and specificity of the oral drug challenge is not known. A detailed discussion of utility of EP study with the patient, especially this particular question, will a change in yearly mortality from 0.8% to 1.7% change your outlook of putting the ICD versus not putting the ICD? RFA seems to have excellent results, and you can get rid of the abnormal substrate. We are not sure who should be the best candidate for RFA. Should we let the patients go through recurrent ICD, the trauma of recurrent ICD shocks before offering them RFA? We do not know. Definitely a frequent ICD shocks, you ablate, and if you cannot ablate or ablation doesn't work, usually ablation works. Infrequent ICD shocks, here's a problem. Now that guy, the first example that I gave, he had one ICD shock 8 months after the ICD implant, and he was absolutely terrified. What is this? I thought I'm going to die. Well, he didn't die. I had to explain to him he didn't die because of the ICD shock. But well, to put it mildly, he didn't find that shock to be very pleasant. So should you go and ablate somebody who's had one ICD shock, or should you put them on quinidine? Well, I told them try and buy quinidine, and I know he will not be able to get quinidine. I told them if you cannot buy quinidine, you buy quinine. I don't know if quinine will work. So those are all the uncertainties involved, and I'll stop that and take questions. Thank you.
Thanks, Dr. Ajit, for a fantastic talk. It was very comprehensive and it was very clear. The clarity was very good. And one thing is, doubt whether in asymptomatic patients you told you don't know what is a close follow-up. Can we offer a ILR in a subset of asymptomatic patients where you suspect a query syncope history, type 2 like pattern with a positive Fleckner challenge test? Can we offer them an ILR?
Yes, if I have a patient with a suggestive syncope, type 2 pattern, and the Fleckner challenge test is positive, I would first offer an ICD. But if it did not accept an ICD, I would put ILR and tell them if you have an ICD, you must be a really remote point. Because why the ILR? We are putting the ILR in the hope, I say hope, in the hope that before sustained VF, there will be non-sustained VF. Nobody knows this point. It's just that I have seen this in a few patients. So it's really stretching it. But yes, if the patient denies it, I would say, okay, even daily remote monitoring, if you see a non-sustained VF, then you get an ILR.
But definitely many patients do have syncope and then they go for this VF episode. So probably nobody has put many ILRs in this group of patients. So we don't know, asymptomatic. We might find some VTs when we put ILR, we don't know.
You might. That's in ICD. That's why I find it interesting. In patients who had ICD shocks, I found that before the ICD shocks, runs of non-sustained VF seem to.
Yeah, that asymptomatic episodes.
Yes,
So
yes,
that is very interesting. That's actually a very good thing. So if we so that will actually encourage us to put an ILR in such group of patients.
Yes, but they should be on daily monitoring. Now, there is no point putting an ILR and monthly monitoring or monthly monitoring.
Any questions? And regarding ablations, you told you will target all the late points in the RVOT. Do you map the whole of the RV and then go for the late points?
Yes, I map the entire RVOT. I don't map the rest of the RV. Because invariably, initially I used to map the whole. I stopped mapping the whole RV because I've never found anything anywhere except the RVOT. Not just me, even the other map. Even in Hyderabad, when we used to map and even other studies, we started by mapping the whole RV, and nobody has ever found anything except in the RVOT. Now I map only the RV, and I map only after flight.
Okay. So you go epicardial, map the RV, and just take what is it only the late points that you ablate, or you just draw a line across the RVs to cut all the possible inhomogeneous areas?
All the inhomogeneous areas. That is, all the areas with rather than late points, it's long duration program. The late points are less commonly found. The most commonly found is a long duration program, like I showed, and the one in Adhimani space. The electrogram spanning the peak of the QRS to beyond that elevation in between. One electrogram span that duration, one long duration electrogram.
Yeah, very late.
Ablating that program seems to get rid of the type 1 type. Isolated potential, if I found in an area not low, I wouldn't touch it. But the moment you give that, voltage drops because of inhomogeneous activation. A normal voltage, so it's like 0.5, less than 0.5 voltage, and long duration electrogram, I wouldn't. Only late electrogram with a more than 0.5 voltage, I wouldn't ablate. That seems to be. It's almost like an core. The central part is always low amplitude, long duration. The isolated late potential, I'm not sure whether to do anything.
Okay, and among the patients you have taken up for epicardial mapping, you have found scars in RVOT in all the patients?
I have found low amplitude on flecainide in all the patients. All patients.
Okay.
I have taken up patients. I have a total experience of 9 patients compared to my experience during my fellowship. So a total experience of 9 patients. Yes, they did not have a low amplitude. They had only an endocardial low amplitude. So 1 out of 9 patients had only an endocardial substance.
But had endocardial?
Yes, had endocardial. All of them had an abdominal. 1 was purely endocardial. All the other 8 is not epicardial. But the study from Paponi and they're all epicardial. Only the Dutch people that there are endocardial.
Okay, thanks.
Group from Arthur Wills that they can find endocardial.
Thanks. That was great information. Thank you. So I think we can.
Yeah.
It's unfortunate that we don't have access to pyridine in our country, right? Or early coupled with initiating polytoxic BP, early retrogressive, Bugada, all nicely controlled and for whatever reason available in the country. It's a very nice drug to have, but we don't have.
I think it was a nice discussion. Are there any queries or questions in the chat box? I think if that is not there, I think Natarajan sir, shall we wind up the session? Because
Thank you.
we had a good heart
Like-
failure session and followed by a good EP session also on asymptomatic and Brugada. So on the outset of CVRS as well as CIPLA, I would thank both the speakers, Dr. Jabir and Dr. Ajit Tachil, for giving a talk. At the same time, both the moderators, Dr. Natarajan and Dr. Praveen Srikumar, especially for long session and well discussion also, and all the people who have attended physically as well as online in this first session of heart failure webinar. So from Cardiovascular Research Society and CIPLA, I thank each and one, and we sign off from here. Thank you all.
Jimmy?
Natarajan sir, yeah. Can you add on?
So how many are present? How many are physically present there?
Physically, we have 20, around 18 or 20. And online, we have, I think, 100 plus. Yeah.
You
So
will
maybe-
send some of the accompaniments that you guys are having there to some of the people who are present online only. Like, for example, Ajit Tachil was smiling very heartily when I said that. I think you should send some accompaniments to our houses.
right. Sure, anyway. I think from here side, our bar is open up. Anyway, that's it.
Don't add fuel to the fire. Thank you very much.
Yeah, thank you, sir. Thank you. Anyway, right. We'll sign off from here. Thank you.
Thank you, sir.